abdinale, most of us feel jittery and we think, okay, it is going to be a very tough time for all of us. And especially if you come across the term scoliosis, then 50 to 70% of your confidence drops down immediately. And most of you will think that it is very, very difficult for you to get through the exam. But I want to make sure, and I want you all to be confident and be sure that if you get a case of scoliosis in your exam, and if you are able to answer the basic questions, then 100% it will be a clear-cut pass for all of you. And it is much more easier to pass than I mean, if you get neck of femur non-union or Sufi or Perthes, because the examiners, they expect only basics as at a postgraduate level. And the scoliosis as such, it's a complex deformity, but if you understand the basics, it is like mathematics. And if you are very much thorough with the basics, then it will be very easy in deciding the treatment or deciding the fusion levels and whatever it is. So if you have any question in between during my lecture or during my talk, you can just raise your hand, or you can post the questions in the chat box. And I think Dr. Cholan, the final year PG, can moderate this if there are any questions in the chat box. And you can just unmute yourself and you can stop me, and you can ask your questions then and there. So that will be easy for all of us. So I am currently practicing as a consultant spine surgeon in Ramachandra Medical University. And I do, nowadays I do only spine work, and I'm not doing active orthopedic work now. So as we all know, let us start with the definition of scoliosis. So we all know that scoliosis is a three-dimensional rotational deformity. Though we see the deformity in a two-dimensional view in an AP X-ray, basically it is a three-dimensional rotational deformity. The spine rotates along the long axis. And it is by definition, if the curve is greater than 10 degrees in the coronal plane, that is in the AP view, as determined by the COBB'S angle. That is how we define scoliosis as per the SRS classification. So this is a gross classification of scoliosis according to me. So usually I tend to classify some things and put it in each box so that it becomes easy for us to diagnose as well as for us to decide treatment, and as a postgraduate for us to write answers accordingly. So scoliosis, it can be because of a compensatory mechanism. Like whenever there is some pelvic abnormality or limb length discrepancy, it could be because of a compensatory mechanism. So it can be because of a compensation when the pelvis or limbs are involved. The other types of scoliosis which we encounter is congenital scoliosis, which is mainly because of failure of formation or failure of segmentation, or it could be combination of both. That is totally different topic. So congenital scoliosis itself is a totally different topic. The treatment, the definitions and everything is totally different. The most commonest type of scoliosis which we see in our clinical practice is idiopathic scoliosis. That is, the cause is unknown. There are three types of idiopathic scoliosis: infantile, juvenile and adolescent. So this is what is given in Campbell. So today we will be dealing with the last box, predominantly adolescent idiopathic scoliosis, because only those type of scoliosis will be kept in exam. Usually you will not get any congenital scoliosis cases. Usually you will be, if at all if they keep a case, it will be a idiopathic scoliosis, wherein you will be able to make out all the findings clearly without any confusions. The next type is neuromuscular scoliosis. That is, it could be because of neuropathic causes or myopathic causes. That is, example like cerebral palsy or in poliomyelitis, etc. When neurofibromatosis, all these things will cause neuromuscular scoliosis. So there is imbalance between the nerves and muscles, and you can develop scoliosis because of that. I'm not getting into that box also, because each box is itself a separate topic if we have to discuss in detail. The final type is syndromic type of scoliosis, wherein you encounter in syndromes like Ehlers-Danlos, MPS or Marfan syndrome, you can get scoliosis because of ligamentous laxity and other syndromic associated with other syndromic features. So this is the gross definition or gross classification of scoliosis. And you can have some other type, like it could be because of infection or tumor. I'm not getting into that particular box because they will not come under scoliosis per se. And the final type is degenerative scoliosis, which occurs in elderly patients. All these type of scoliosis, which I said, compensatory, congenital, idiopathic or syndromic, will usually occur in young children, whereas degenerative type occurs in elderly patients as a result of degeneration of the lumbar spine. So that again is a different box. So today we'll see the basics of scoliosis, that is all the definitions, classifications are for idiopathic scoliosis, and we'll concentrate on adolescent scoliosis. I'll say a few points about infantile and juvenile when we cross across these slides. So if at all, if you get any case of scoliosis, you have to ask the history like in any other case: onset, duration, progression. Usually the informant will be parents, because the scoliosis will be seen in children, and usually the onset will be, they'll say, for 1 year or 1.5 years, but the curve may be very severe because they will not be noticing the scoliosis unless there is gross shoulder imbalance. So usually it will be at a later date, and this occurs, adolescent scoliosis occurs after 10 to 12 years of age, after the growth spurt. So usually children will not expose their body to their parents. So parents also will not be aware unless they see a gross scoliosis. However, school teachers play a vital role in diagnosing this kind of scoliosis. So school screening is very, very important. And as a part of the Association of Spine Surgeons of India, we have started nationwide school screening programs, which is quite routine in all Western countries, but we are starting in our country for the first time. So we are starting to do that in all schools in Chennai. So we have zonal areas, and that is very, very important. So the teachers should be aware of diagnosing scoliosis. And next, the most important thing, whenever you come across any scoliosis, you have to ask the antenatal, natal and postnatal history. That is for sure, whether it is congenital, adolescent, whatever type. Then the age of menarche. Mostly scoliosis is common in idiopathic scoliosis is common in females. So age of menarche plays a vital role in treatment, in decision making in treatment, whether you have to operate or whether you have to observe. So that is very, very important. And the next most important thing is pain. So usually this kind of idiopathic scoliosis will be painless. Whenever someone says that he or she has pain, then it is a red flag. Immediately you have to order all the investigations, including CT scan and MRI. Because why? Anyone? Because pain associated with scoliosis is usually seen in osteoma. The patient will complain classically of night pain, and the patient will have scoliosis. And when you do CT scan, you may miss it in MRI also. So when you do CT scan, you will be able to pick up the nidus, which will be usually at the apex of the skull. You should not treat like any other. You should not just take X-ray and say, okay, it is just 20 degree, we can wait and watch. No, pain is a red flag. And then you have to ask for the neurology, whether the patient has any numbness, weakness, or any other difficulties, bowel, bladder involvement. Again, neurology will be normal in most of the idiopathic scoliosis. In case of syndromic or in case of other neuromuscular pathologies, the neurology will be affected. Now coming to the clinical examination. So I'll go step by step. First of all, just like any other examination of spine, you have to start by saying that I examined with the patient in standing, sitting and supine position. But predominantly scoliosis examination is by standing position, and you have to stand behind the patient first for inspection, palpation, everything. So your predominant work is from behind. So you have to say on inspection from the front, sides and from the back. And then you have to say the following things. The head is centered in position. The head is in center. On inspection, you must be able to see the head in line with the gluteal fold. This is very, very important. Head is centered means the curve is compensated, which means there is some other curve in the bottom or at the top which is compensating for the main curve. So this is very, very important. Central position of the head is very, very important. Suppose if this head is not in the center and if it is tilted to one side, it means the patient is decompensated, because it means the patient has truncal imbalance. The trunk is going towards one side. That is called as coronal decompensation, and that is not common in idiopathic scoliosis. That is usually common in other types of scoliosis, but in idiopathic scoliosis usually it will be a compensated curve. The next one is level of shoulders. See, it is like mathematics. Whenever you see right side predominant curve and right sided shoulder is high, that is normal. Suppose if the convexity of the thoracic curve is on the right side, the right shoulder should be at a higher level. Suppose the convex, for example, in this girl, you are able to see the curve on the right side. The right shoulder is at a higher level. That is the equation. Suppose the convexity of the curve is on the right side, and if the left shoulder is at a higher level, it means there is a proximal thoracic curve, which will usually be missed in the X-ray, and it is usually, most of the times, it is picked up only by clinical examination. So right-sided convexity and left shoulder up, you have to be very careful, and you have to look for a proximal thoracic or a cervicothoracic rigid curve. That means the opposite shoulder will be at a higher level, and it is very, very important in decision making and while operating, and to give proper results for the patient after surgery. Again, the level of scapula. The scapula will be elevated on the convexity side, on the convex side of the curve. If the convexity is on the right side, the right scapula will be at a higher level. Both the spine of the scapula and inferior angle of the scapula will be at a higher level. I have drawn two lines along the inferior border or inferior angle of scapula. You can see the right scapula is at a higher level. Then comes the level of iliac crest. Usually the iliac crest will be elevated on the convex side of the lumbar curve, not on the thoracic curve. It is just like the shoulder. Shoulder is for thoracic curve, iliac crest is for the lumbar curve. So the iliac crest will be elevated on the convex side. That is, usually it will be elevated on the opposite side, so that the patient is able to balance and stand straight. So all these things you should see from behind, and then you look for the dimple of Venus again for the posterior superior iliac spine. The next thing is you have to know the type of the curve and location of the curve. That is based on the convexity of the curve. So any curve has a convex side and a concave side. So the scoliosis is named, the region of the scoliosis is named based on the side of the scoliosis is named based on the convexity of the curve. Suppose if the convexity is on the right side, like in this, for example, in this picture, it is called as right-sided scoliosis. Then you should know the location where it is located, whether it is in the thoracic level or whether it is in the thoracolumbar level or in the lumbar level. That is usually determined by the apex of the curve. Usually in exams, if you say arbitrarily that, for example, in this case, the apex of the curve is arbitrarily at around D7 to D8 level, which corresponds to the inferior angle of scapula. If you say this is a thoracic curve, because any curve with apex between D4 and D11, 12, it is called as a thoracic curve. Any curve with apex at around D11, 12, it is called as a thoracolumbar curve. I'll come to the definitions later. Any curve with apex at between L1 to L5, it is called as a lumbar curve. So if you can say arbitrarily, then there is no problem. And again, you have to confirm all these findings in palpation. How do you do in palpation? You just palpate the spinous process, use your skin pencil, mark the spinous processes, and based on the surface marking, that is the spine of the scapula usually corresponds to D4, inferior angle corresponds to D7, iliac crest corresponds to L5, and the dimple of Venus corresponds to PSIS or S2. Based on this, if you are able to grossly tell the location of the curve, the examiners will accept it. This is for exam point of view, because clinical practice wise, anyway, you're going to take X-ray and it will be very obvious in the X-ray. The next thing which you have to look at is the arm thorax. That is the distance between the medial side of the arm and the lateral chest wall. That forms the arm thorax distance. Why is it significant? This is again a common sense. Whenever there is a curve, the body is bending towards one side. So the arm thorax distance will be increased on the concave side, whereas it will be decreased, as you can see in this picture, it will be decreased on the convex side. So that is important, which means it usually denotes the severity of the curve. Then you have to assess the patient by standing in front of the patient. The most important thing is again the shoulder level. But when you are standing in front of the patient, you have to look at the level of clavicle. The level of clavicle again is important in X-ray also. So that is called as the clavicular line. So whether both the clavicles appears to be in the same line or there is tilting of one clavicle, again it will be elevated on the convex side. And this interpupillary angle we need not mention in the exam, but whenever there is gross deformity, the pupil on the convex side will be at a higher level, but usually in exams they don't expect it. So you can stop with the level of clavicles and the clavicular line. Clavicular line is very, very important for treatment modality. Your entire treatment is based on the clavicular line for shoulder balance. Next comes on inspection from the sides. So you stand by the side of the patient and you look for the sagittal alignment. So whether the thoracic kyphosis and lumbar lordosis is normal. So usually, see, whenever I was a PG, I used to, when I was a second year PG, they used to talk about scoliosis. Immediately, I used to think as it is kyphoscoliosis, kyphoscoliosis. Kyphosis and scoliosis will go together. No, that is not so. In adolescent idiopathic or most of the cases of idiopathic scoliosis, there will be hypokyphosis of the thoracic spine. It is not a kyphoscoliosis. It is a hypokyphosis. Whenever you encounter a situation of kyphosis along with scoliosis, it is usually seen in syndromic cases or congenital cases. This is another point to distinguish congenital and idiopathic. This is in most of the cases. However, it can occur in adolescent also, idiopathic also, but most of the cases of idiopathic scoliosis will have hypokyphosis because, as I told, it's a three-dimensional rotation. So the kyphosis in the lateral view rotates and it becomes the scoliosis on the AP view. That is the basic pathology. Then you have to ask the patient to bend forward with knee in extension, and you have to sit down at the level of the patient's back to avoid parallax error. To visualize, your eyes should be in line with the patient's back to avoid parallax error, to look for the rib hump. So this is the basic pathology for rib hump. Whenever there is a three-dimensional rotational deformity, there will be the ribs will be pushed posteriorly and the entire thoracic cage will be pushed posteriorly on the convex side because the vertebra is rotating. Similarly, the spinous process will deviate towards the concave side. So all the posterior elements on the concave side, that is the pedicle, the lamina, everything will be very thin and hypoplastic on the concave side, whereas the lamina, pedicle, transverse process will be developed and it will be normal on the convex side, and the ribs will be prominent on the convex side. Okay, this you have to understand. Since the vertebra rotates, the entire concave structures goes inside, it gets inside because of a vertebral deformation. So that is why you get thoracic rib hump. It also points, the Adams forward bending test also tells us about the rigidity of the curve. Then you have to look for gait, hip joint examination, and neurocutaneous markers is very, very important to mention in a case of scoliosis. The examiners will expect you to mention this because it could be congenital malformations, congenital scoliosis, and about 20 to 40% of the patients with idiopathic scoliosis will have some spinal dystrophism. Nowadays, latest papers, they have quoted up to 60%. The maximum is up to 60% can have problems in the spinal cord. Spinal dystrophism like diastomatomyelia, myelocele, myelomeningocele can be present in these patients. Then any scoliosis examination is incomplete without limb length measurement. You have to definitely measure the apparent and true length, everything like you do in your hip cases. Finally, neurological examination. As I said, most of the patients will be neurologically intact. Now, the next most common thing which we encounter in our clinical practice is sometimes a patient will come with cross tilt. There will be the trunk will be tilted to one side. How do you differentiate that? That is called as list, which is otherwise called as sciatic list. Sciatic list occurs mainly due to disc prolapse, predominantly due to disc prolapse compressing the nerve, just like a boil under your axilla. If you get a boil under your axilla, either you lift your shoulder like this, or you tilt your body and lift your shoulder like this. The same thing happens whenever a disc comes out and presses the nerve. The entire body tilts towards one side, thereby giving space for the nerve to expand. That is called a sciatic list. How do you differentiate a scoliotic curve from a sciatic list? This, if it occurs in a young age patient, I have seen 2 or 3 cases where it was diagnosed as scoliosis and the patient was advised surgery. And however, the patients weren't convinced, and when they came and when we did MRI, it was a huge disc prolapse because of the following features. Usually, the scoliotic curve will be on the right side, right-sided thoracic adolescent scoliosis, and sciatic list depends on the side of pathology. Usually, it will be a compensated one. As I said, the shoulder will be balanced over pelvis and head will be in the center. Whereas in sciatic list, the patient will be completely like this. The head will be totally off-centered. And scoliotic curve, it will be painless predominantly, whereas sciatic list, the patient will have severe pain. Usually scoliotic list will be associated with forward stooped posture or forward bent posture, again because it increases the space for the nerve root. Neurology will be normal in scoliotic curve, whereas in sciatic list the patient will have radiating pain, the patient will have numbness or some weakness will be present in these kind of cases. So it is always very, very important. When you do an X-ray, in case of sciatic list, you will not be able to see the rotation of the vertebra. You will be able to see all the pedicles evenly like this. When you draw a line connecting all the spinous processes, it will not be in the straight line. It will be completely off-centered. So, which means whenever there is a complete truncal shift without rotation of the vertebra, it means it is mostly a sciatic list. And the history will be, the deformity will usually present after the onset of pain, usually. Okay, and it will be for a short period of time because it is after disc prolapse. Coming to the radiological investigations, whenever you get a scoliosis, lot of confusion arises when it comes to radiology. What is the definition of this vertebra, that vertebra, what to do, how to describe. So I'll try to make it as simple as possible. So whenever you come across any scoliosis, you have to get a full length AP view starting from occiput to the bilateral femoral heads, but in most of the centers it will not be available. In those cases, at least from C6 to the sacrum or pelvis. That is mandatory because you must be able to see C7 at any cost, and you must be able to see below at least up to the S2 level, so that you must be able to visualize the pelvis. And a lateral view. This is very, very important. Again, as far as possible, you should get from C2 to bilateral femoral heads. Again, most of the centers will not be having this facility. In those cases, you should be able to see at least from C6 to the sacrum, at least till S2 or S3, because you have to visualize the sacrum, the endpoint. That is very, very important. And you have to look for the kyphosis and lordosis in the lateral view X-ray. Then the most important thing in scoliosis is side bending film. So all your definition, your classification, your treatment, everything is based on the side bending films. Without side bending films, you will not be able to define a curve or make any treatment protocol. So side bending film asks the patient to stand straight with the knees extended with feet together, and ask the patient to bend by the side as much as possible. So right-sided side bending view and left-sided side bending view. Can you see the difference in the left picture and right picture? The right picture you are able to see the scoliosis, whereas in the left picture the scoliosis is correcting. So side bending film, the main ideology behind side bending film is it gives you an idea of the flexibility of the curve, how much the curve is able to correct. That's what you will be able to tell in a side bending film. So these are the examples of side bending film. So you ask the patient to bend on either sides, and you can see in this patient it is almost correcting. So if it is correcting like this, you can manage it conservatively. There is no hurry in operating. The place where I did my fellowship, we used to do traction film, and it was significantly useful. Even now, I personally practice traction film, though it is not recommended in any classification systems, but it gives you a very good idea of the amount of correction which you can get. You pull the patient's upper limbs and you ask the X-ray technician to pull the lower limbs, and you pull the upper limbs, and you give as much as traction as possible, and you get a good AP view, and you will be able to see the amount of correction. So usually what we found, we did a study where I did my fellowship in Delhi. We found that the amount of correction which you get post-operatively usually matches with your traction film, which is more than your side bending film. So that gives a rough idea. Bolster bending film is followed in Hong Kong. It is a very good practice, but however, we are not following it, and there are no classifications which are based on this, which is being followed widely. They place a bolster, hard bolster, and they try to correct the curve as much as possible, and they take the X-ray. So that is the bolster bending film. We are not using in our country on a regular basis. Again, STAGNARA view, after the invent of CT scan and other things, we are not using STAGNARA view also. STAGNARA view was mainly to nullify the rotational element of the scoliosis, so that you are able to see the pedicles and all the structures clearly by placing a radiograph cassette along parallel to the medial aspect of the rib prominence. Since it is given in Campbell, I think you should know what it is, but we are not following it routinely. Now coming to the parameters. So let us go one by one. The first and foremost thing is in the AP view. You have to draw two lines. The first line is called as the CSVL, Central Sacral Vertical Line. So the name itself suggests it passes through the center of sacrum. You draw along the spinous processes of S2 and S1 a straight line. That is called a central sacral vertical line. So CSVL should be drawn from below up. The next one is C7 plumb line. That is, you draw a line vertically down from the midpoint of C7. That is called a C7 plumb line. Usually, most of the cases in normal individuals and most of the adolescent scoliosis, this will be merging. That is, the CSVL and the C7 plumb line will merge together. In other words, the difference between these two lines will be less than 2 to 3 millimeters, which means it is a compensated curve. As I said, the curve is compensated. In other words, the head is being centered over the pelvis. So it means the curve is a relatively compensated one, and it is easier to treat. Okay, so the CSVL and C7 plumb line is very, very important. Again, it is very important because you have to measure the apical vertebral translation only from these lines. I'll come to that when I deal with the apical vertebra. So in the AP view, you draw a line from below upwards and one line from above downwards. So these two lines should merge with each other in most of the cases. Coming to the sagittal balance, you drop a line from the midpoint of C7, you drop a vertical line down. Most of the case, in normal cases, it should fall on the posterior superior corner of S1, as you see in the picture in the image which I've shown, and it should pass behind or posterior to the femoral heads. That is a normal, or it should pass through the femoral heads. That means it is normal. If it is passing behind the posterior superior corner, it is called as negative. If it is passing anterior to the posterior superior corner of S1, it is called as positive sagittal balance. Negative sagittal balance is usually better than positive sagittal balance. The another point is the normal sagittal balance is between minus 5 mm to plus 5 mm. That is 5 mm behind and 5 mm in front of the posterior superior iliac spine. That is the normal. This 10 millimeter window is the normal sagittal alignment. So this is called as the C7 plumb line, or the sagittal SVA, or sagittal vertical axis. Okay, so that is for sagittal balance. Next comes the rotation. So assessing the rotation is by the Nash and Mohr method. You do it in the AP view. You look See, this is the convex side. You can see in the picture very clearly. This is the convex and that is the concave side. Whenever the pedicle, both the pedicles appear equally in a vertebra, it is called as grade 0, no rotation. That vertebra is called as a neutral vertebra. Name itself denotes it is neutral. It doesn't go to any side. When the pedicle is slightly towards the midline or towards 2/3 of the midline, it is called as grade 1 or grade 2. Usually it is very difficult to differentiate between grade 1 and grade 2. So that is called as grade 1 and grade 2. So once the pedicle starts moving on one side, the other pedicle will be less visualized because it is a rotational element. It is like this. Now it is rotating. So one will be visualized more, the other will be visualized less. Grade 3 is when only one pedicle is visualized and that is in the center, that is grade 3. Grade 4 is when the pedicle is beyond the midline. You should not think that it is the opposite side pedicle. That is why they have given on the convex and concave side. And usually grade 4 amount of rotation will be seen as a lateral view in the AP view. That is, the vertebra will appear as a lateral view in the AP view because of significant amount of rotation. Now, for completion's sake, I'll just add up these two things. This rib vertebral angle, this is not used for adolescent scoliosis. However, it is used predominantly for infantile and juvenile scoliosis, of juvenile type of idiopathic scoliosis. This was devised, this term was coined or devised by Mehta. It is called as Mehta's rib vertebral angle, and she herself had scoliosis. And this angle is measured by drawing a line perpendicular. First you draw a line along the lower end plate of the apical vertebra and draw a perpendicular from the end plate and then a line along the rib. So the angle formed by the green line and the vertical red line in the picture is called as the rib vertebral angle. And the RVAD is the difference between the right side or the convex side and the convex side. It has to be measured on the AP view apical vertebra. So if the rib vertebral angle difference is less than 20 degree, she has found that the progression of the curve will be less. You can wait. If it is more than 20 degree, the progression of the curve will be more, and you have to warn the patient about that. Again, there is another terminology called as rib face. Phase 1 means the convex rib at the apex does not overlap over the vertebral body. Phase 2 is when convex rib overlaps the vertebral body, then it means a poor prognosis or the curve will progress faster. It is basically a developmental malformation. So it is so much rotated that the rib goes and overlaps the vertebra. It is rather than staying in its place, it goes and overlaps the vertebra because of the rotation, and there is no time for it to adapt itself. So the moment the rib, vertebra is rotating, the rib goes above it. It means the progression is faster. Clinically, the next most important thing which we have to see is the RISSER'S grade. It is the ossification of iliac apophysis. It is very, very important to know the skeletal maturity, and your treatment will depend on that. Grade 0 is absent. You will not be able to see anything. Grade 1 is 0 to 25%. It is from lateral to medial. Okay. Grade 2 is 25 to 50%. Grade 3 is 51 to 75%. Grade 4 is 75 to 100%. See, this is very, very important. Grade 4 is the entire iliac apophysis will be visible. 100% will be visible. Whereas grade 5 is, it is fused. The apophysis, you will not be able to see a separate apophysis. It will be fused with the vertebra. So this case you can see almost, I'm not able to use my mouse in my computer. You can see it is almost grade 3. It has come to, it is from grade 2 to grade 3. It is transition zone. Okay. So still some amount of growth is left. The other radiological parameter which you can see is the teardrop. So that again gives you good idea about the skeletal maturity. And ideally speaking, you have to look for the Tanner staging system for breast, for pubic hair, everything. But we are not doing it on a routine basis. But ideally speaking, at least you should know everything, all those things. Now coming to the parameters. So now comes a little bit confusing part. So end vertebra, I'll go into the definitions. End vertebra. What do you mean by end vertebra? As the name suggests, it marks the end of the curve. So there has to be any curve has to end in the top as well as in the bottom. So there will be two end vertebra. That is the upper end vertebra, lower end vertebra. It is called as the UEV or LEV. The end vertebra is the vertebra which tilts maximally into the curve. So whenever you take a curve, the curve is an incomplete form of a circle. Okay, so the curve ends means the vertebra which is tilting maximally into the curve, it is called as the end vertebra. The next intervertebral place, either above the superior end vertebra or below the inferior end vertebra, is wider on the concave side. So I'll explain how it is. See, you draw lines along the end plates of the vertebra. You see the top line, it is converging into the curve. It is converging into the curve. Then comes the next vertebra. Again, it is converging into the curve. Okay. Whereas you come to the third vertebra, it is diverging from the curve, whereas it is converging to the opposite side, which means that particular vertebra, the pink color arrow, is the end vertebra of the inferior end vertebra of the curve above. Understood? And it is the usually it is the least rotated, not neutral vertebra. It is usually the least rotated vertebra of the curve. Then comes the apical vertebra. It is very simple. The vertebra, or it could be a disc space also. Here in this example, in this X-ray which I have put, it is the disc space. So the vertebra or the disc space which is most laterally deviated is called as the apical vertebra. And obviously it will be least tilted because it is center portion of the curve. It will not be least tilted. It will be horizontal. It will be maximally displaced. However, it is the maximally rotated vertebra in a curve. So when it rotates, the maximum rotation takes place in the apical vertebra, whereas the least rotation takes in the end vertebra. The end vertebra just tilts. It doesn't rotate. So you have to imagine there is something called as tilting. There is something called as rotation. So the apical vertebra rotates maximally and goes like this, translates. Whereas the end vertebra, it comes like this and it tilts. It doesn't rotate much. So this is very, very important. Then comes the stable vertebra. See, when Harrington's system was being used many years back, even before the advent of pedicle screws, scoliosis, they thought it is a two-dimensional deformity. It is curved like this. So what you have to do, you have to straighten it. So common sense wise, what you will do, you will distract the concave portion. You distract like this, and you distract the convex portion. You distract the concave portion, and you have to compress the convex portion. So Harrington instrumentation system was mainly a distraction device. They had anchors above, anchors below, and they distracted it like this. So the curve like this became like this. They did not concentrate on the rotation. That resulted in various problems. So that system and Harrington's principle was predominantly based on the stable zone. That is, it is from stable vertebra to stable vertebra. So how did they decide the stable vertebra? So any vertebra which is centered over the sacrum was considered as stable vertebra because it is stable. It is not translating. It is not moving much. So it is like the foundation. We say, no, the foundation of any building should be strong. So that is the foundation of the instrumentation. So how did they determine that? The vertebra which is most closely bisected by the CSVL, central sacral vertical line, was called as the stable vertebra. So you draw a CSVL, central sacral vertical line, and if the central sacral vertical line, the vertebra which is bisected by the central sacral vertebral line, is called as the stable vertebra. If it is not bisected exactly also, even the predominant portion is bisected, that is taken as the stable vertebra. See, you may think why there are so many definitions. Each vertebral definition has a significant impact in the treatment modalities. But at a postgraduate level, you should know what is what. What is end vertebra, what is apical, what is stable, and what is neutral. Neutral is very simple. Any vertebra which is not rotated is called as neutral vertebra. So in AP radiograph, like this, you look at the spinous process. It should be in the center of the vertebra. You look at both the eyes. It is like a face, 2 eyes and 1 nose. You'll all be knowing that. Both the eyes should be equal in size and equidistant from the spinous process. Then that is the neutral vertebra. If one eye is bigger than the other, then it means the vertebra is rotated. So usually neutral vertebra, by common sense, it has to be between the two curves. It has to be between the transition of the curves. Okay, so when there is one curve is ending and the other curve is starting, at that place you will be having the neutral vertebra. So then comes the definition of curve. As I told previously, how do you define, sir, how do I say it is a thoracic curve? What is the definition? As per Scoliosis Research Society definition, cervicothoracic is when the apex is at C7 or T1. Thoracic is between T2 and T11, 12. Thoracolumbar when the apex is at T12 or L1. Lumbar when it is between L2, L2. And lumbosacral when it is at L5, S1. Okay, this is how it has been this thing. The next most important thing and the most commonest thing, the first thing which we do in any x-ray is marking the COBB'S angle. So you mark the end vertebra up and end vertebra down. You draw a line along the superior end vertebra of the, superior border of superior, it's like a rhyme, superior border of superior end vertebra, inferior border of inferior end vertebra. Draw 2 lines. If they merge each other, if they form an angle, that is the COBB'S angle. Suppose if they don't form an angle, if it is widely opened, then you draw perpendiculars from 2 lines and that marks the COBB angle. The original definition by COBB is by dropping the perpendicular lines. But now since our softwares and other things have come, we can just draw the angle directly. You have to look for all the curves. You have to look for a thoracic curve. You have to look keenly for a lumbar curve, and very, very keenly and much more carefully for a proximal thoracic curve. Is there any doubt till now? Because now I'm going to go into the next slightly confusing thing. If you're not able to understand anything now, you can just unmute yourself and you can just introduce and ask the question. Or if there are any messages posted, Dr. Cholan can moderate if there is.
Sudhir, this is Dr. Ramprasad.
Yes, sir.
Can you repeat that apical vertebra slide?
Yes, sir. The apical vertebra is the vertebra which is maximally displaced, laterally deviated and maximally displaced from the CSVL. So it means it is the farthermost vertebra or the disc space, which is the tip, which is the farthermost from CSVL, marks the apical vertebra. It is usually the least tilted because since it is the center portion of the curve, it will not be tilted. It will be least tilted, but it is most displaced, most rotated. So translation is maximum, rotation is maximum, but tilting is less. Whereas neutral vertebra, tilting is maximally tilted and rotation is less. That is how you differentiate between these two.
Okay, thank you.
Okay, sir. Okay, sir. Now I'll just get into the other slightly confusing part now, much more, but I'll try to make it as simple as possible. So we all know whenever scoliosis comes, we talk of terms like major curve, minor curve, structural curve, non-structural curve. So what is a major curve? Let us make it very simple. Major curve, the largest COBB'S angle measurement is major curve. Whichever number is big, that is major curve. If 90 degree, if a patient has 2 curves, 90 degree and 45 degree, 90 degree is big, that is the major curve. No doubt. What is the minor curve? All other curves are called as minor curves with structural criteria applied. I'll come to that point. Now, what is a structural curve and what is a non-structural curve? See, whenever scoliosis starts, it usually starts as a single curve. It usually, you underline the word usually. Most of the times, it usually starts as a right-sided thoracic curve in young girls. So it starts as a right-sided bending. So it bends on the right side. So when the patient bends like this, when the right shoulder goes up, automatically the body will try to compensate itself by forming a curve below or above. Usually it is a compensatory curve below. That is the lumbar curve. So when you're tilting like this, the body tends and the spine, since it is a moldable structure like a clay in young children, it bends and it forms a compensatory curve. So usually the major curve, the curve which develops first, becomes a structural curve. It will not correct. And the curves which develop later as compensatory curves, they are usually non-structural curves and they correct. So they did various studies and they wanted to know, we have to have a value. We can't say this is structural, this is non-structural. So they gave a particular value as greater than or equal to 25° in side bending COBB'S. So that is why the side bending x-rays are very, very important. The convex side bending COBB'S, suppose if a curve is a right-sided curve and right-sided bending view is greater than or equal to 25°, it means it is a structural curve by definition. Okay, for example, you are getting a curve of 50° in normal AP view. You are doing a side bending COBB'S. If the curve is 30°, it means it is a structural curve. If the curve is 22°, it becomes a non-structural curve. Okay, this definition is very, very important. If you have any doubt, you stop me and ask me here, because the treatment and everything is based on this structurality of the curve. This structurality of the curve is very, very important. Non-structural curves are curves that correct you completely. That completely word is they mean by less than 20° when patient bends towards the convexity. They are usually compensatory curves. But however, if the patient is neglected for about 10 years or 5 years or 7 years without any treatment, this non-structural curve will say, I tried my level best, but nobody is treating you. So now I am also going to become structural. I will not give way. I will also become structural curves. So as years passes by, these non-structural curves also may become structural. That is why treating scoliosis at an early age is very, very, very vital. You can just deal with one curve when you treat at a younger age, whereas the same patient, if you leave and treat after 10 years, you may have to treat by fusing the entire spine by taking all the curves into consideration. So this definition is very, very important. I'll give you an example now very clearly. So this is a patient which I operated recently. So you can see there are 3 curves in this patient. Now any PG so what
வரதராஜன் இருக்கியா, லைன்ல இருக்கியா வரதராஜன்? வரதராஜனே வரவே மாட்டேங்கிறானே. சோடன் வரதராஜன் இல்லையா?
குட் ஈவினிங் திரு.
இருக்கான் சார், வரதராஜன் இருக்கான் சார்.
அருண் வாங்க.
நான் ஆல்ரெடி லைன்ல தான் இருக்கேன். கேட்டுட்டாங்க.
ரைட் வாங்க வாங்க வாங்க.
வரதராஜன் இருக்கான் சார்.
வரதா எங்க இருக்க? சரி, எட்வின் இருக்கானா? ஜோ சீக்கிரம் ஆன்சர் பண்ணுங்கப்பா.
What type of curve is this? What type of curve? You leave alone the angles now. I'm not getting into the angles. So what type of curve is this?
This is looks like thoracic curve.
Which side?
Right-sided thoracic. Right-sided thoracic curve.
Right-sided. Are you able to see? See, whenever you see an AP view, there will be one curve which will be very obvious. Okay, so thoracic curve is very obvious. Then you have to look for the other curves. What are the other curves which you are able to visualize?
So lumbar curve. Lumbar.
Correct. Left-sided lumbar curve, because the convexity is on the left, so there is a left-sided lumbar curve. When if I had not mentioned the angle, most of us will try to miss the proximal thoracic curve. Correct?
Yes, sir. Yes,
but the point which I said, if you remember, what is happening to the shoulder levels?
Shoulder level should be to the convex side, but here it is higher. The left side.
Yeah. So normally in this kind of right-sided thoracic curve, the right shoulder should be at a higher level, because the shoulder on the convex side should be high. But what is happening here? The left side is high. Immediately you should look for a proximal thoracic curve. Understood? So that is very, very important. So this means there is a proximal thoracic curve. Okay. Though it may not be very obvious like the main thoracic curve. See the angle. It is 47°. Okay. But it is looking almost straight because the curve is like that in the proximal thoracic region. Okay. Now what is the major curve?
Thoracic, that is
Thoracic, sir.
Thoracic.
Thoracic.
I thought of putting this animation for discussion, but there will be video lag in Zoom, so I just mentioned everything here. So the major curve is a thoracic curve, and the rest two curves becomes minor curves. In any scoliosis, there can be only one major curve. All the other curves will be minor curves. Okay. So the major curve is very obvious. 100 the period number, so that's major curve. Okay, va. Ipo, is this structural or non-structural? How will you say that? If someone shows you this X-ray and asks you which is a structural and non-structural curve, you should not answer. You should say, sir, I would like to see the lateral X-rays. I would like to see the lateral X-rays, sir, before commenting on non-structural. So before commenting on structurality of the curve, sir, I would like to see the side bending views. That is very, very important. That should be your answer. Okay, without seeing the side bending view, never ever comment on the structurality of the curve. So that is very, very important. Okay, now what is happening on the convex bending? That is the left side for lumbar curve. Left side is the convex side. Understood? So what is happening on the convex bending? I have drawn the Cobb's angle. The red color lines are along the end plates. It is not meeting. So I have drawn 90-degree angle from both the red lines. That is the yellow line. So it is basically 5 degree. So from that much amount of degree, it has come to 5 degree. So lumbar curve becomes
compensating,
non-structural. Whereas the proximal thoracic from 47 degrees, it is correcting only to 41 degrees. So that is a structural curve. Again, the thoracic curve from 100 degrees, it is correcting to just 99 degrees. So that is a structural curve. So in this, lumbar curve becomes non-structural, whereas proximal thoracic becomes a structural curve. Though the lumbar curve, that is what I have given in the pink box, though the lumbar curve is greater than the proximal thoracic in AP view, lumbar becomes non-structural because of the flexibility. This is very, very, very important. If you have any doubts, you please clear it here. It is very important. Knowing about the structurality of the curve is very important. Just because the number is more in the AP view, you cannot term it as a structural or rigid or anything. It is all dependent on the side bending view. Understood?
Sir,
Yes.
What is the link between the side bending views and Adams forward bending views? What is the link between our two links?
Yeah, Adams forward bending test is a clinical examination test. You have to know the amount of rib prominence, thoracic deformation. See, clinically, what we do is whenever we do a Adams forward bending test and see, and if we see the rib vertebral prominence, you have something called a scoliometer measurements. And if it is very, very prominent, then intraoperatively, you may have to do costoplasty. That is, you may have to cut off few ribs to make it appear better post-operatively. It is basically a cosmetic procedure. Okay. So Adams forward bending test shows the rigidity of the curve as well as the amount of thoracic cage rotation. Okay. That is Adams forward bending test. That is a clinical test. We do not link that with the radiological examination. Understood?
Sir, good evening. Dr. Arun, orthopedic surgeon.
Sir,
Please,
sir. Hello, sir. Good evening, sir.
Can I see the previous slide, please?
Yes, sir. Yes, sir.
So not this one, yeah. See, in this, you told me that the thoracic curve is around 100 degree, no?
Yes, sir.
So that itself says that it is structural, it's not so.
Illa, sir. For example, in the case like it is a major curve, sir. Suppose if the same 100-degree curve on bending view becomes 20 degree, it is called as a non-structural curve.
Non-structural curve, okay.
Yes.
Now I'm asking about this picture alone.
No, sir. We cannot say it is structural or not with this picture, sir. Side bending is mandatory.
Side bending is mandatory, but here it is 100 in the AP view. So after side bending, it is coming to 41 or something like that,
99. It is coming to 99.
Oh, 99. Okay.
It is a structural curve. But without looking at the side bending view, structurality cannot be defined. Basically.
Okay.
Sudhir, sir.
Yes. Yes.
On the AP view, can we tell it's a major curve?
Yeah, major curve. Yes, 100% major or minor curve only with the AP view, not with the side bending view.
So
Side
what if the
bending-
side bending view decreases and other curve is more than?
That's what. Major curve or minor curve is based only on the normal standing AP view. Side bending is for structurality. Major or minor curve is based on AP view.
Okay.
Yeah. Side bending for yes. Side bending for structurality. You are knowing the structurality of the curve by side bending views.
Okay, sir.
Yeah.
And this is Dr. Ramprasad, sir.
Yes, sir.
Sudhir, I'm here. Okay, right. So throughout the course of your presentation,
Yes, sir.
one thing I observed was all of your X-rays you are viewing from behind.
Yes, sir. That is I
So,
forgot to tell. Yeah.
as a
Yes,
spine surgeon,
correct.
this is very important because
Correct.
we are looking at the spine from behind clinically.
Correct.
Radiologically also we are looking from behind. So PGs must be thinking, wondering why this R symbol is reversed in all the X-rays and R is going on the opposite side.
Wait, Vandra.
So,
Correct.
so I think that message also should
Yeah,
be conveyed.
100%, sir. Thank you for reminding, sir. That is a
Yeah.
very vital point. I thought of mentioning it. Whenever you are dealing a scoliosis X-ray, you should you should reverse the X-ray. Your right and patient's right should be on the same side. Because you are dealing with the curve posteriorly, or viewing everything from posteriorly, so everything should be on. So your right should be on the patient's right. So that is mandatory. And so after you do these X-ray measurements, you have to get MRI whole spine, and it is mandatory. There is no doubt whether it is a clear-cut, straightforward adolescent idiopathic scoliosis. You have to get MRI whole spine for medico-legal reasons. If you are not getting MRI whole spine, and if the patient lands up in some trouble after surgery, then it is a very big medico-legal issue. You are supposed to get it because, as I said, latest article which was published in 2019, they have told up to maximum of 61%, even up to 60 patients out of 100 patients can have some form of spinal dystrophism changes in idiopathic scoliosis. Congenital scoliosis, most of them will have. Most of them will have some spinal dystrophism changes. Whereas in idiopathic scoliosis, we think that it is just idiopathic, nothing to be done, it is straightforward. Yes, no, you have to get. And if the patient is affordable, it is better to go ahead and get a CT scan to know the anatomy of the each and every vertebra. So I always do CT scan, all these X-rays, and MRI scan for all the patients. So now, since LENKE classification has been given in Campbell, I'll just get into like 3 or 4 slides about LENKE classification. Now, I think as an orthopedic surgeon, we have to be aware of LENKE classification because now the entire world is following LENKE's classification for treatment of scoliosis. Though I'm not getting into the in-depth treatment modalities, I feel that it is a complicated system. And there are many pitfalls in LENKE's classification, and there are some classifications which are coming up in a full-fledged way. Maybe in another 5 to 10 years, those classification systems will take over the LENKE's classification system. But since this is discussed in Campbell, I'll just talk about this. Unfortunately, as orthopedic surgeons, we don't have the patience to by heart things or to read so many things in a single table. But unfortunately, LENKE's classification, we have to by heart this. So basically, there are 3 parts. One is a curve type. The other one is a lumbar spine modifier. The next one is a thoracic sagittal profile modifier. Curve type, there are 6 types. You have to by heart this. First one is main thoracic. Most of the idiopathic, and again, LENKE's classification is only for idiopathic scoliosis. It is not for congenital. It is for not for new. I've seen many doctors using LENKE's classification for congenital scoliosis or neuromuscular scoliosis. No, it cannot be used. This is only for adolescent idiopathic scoliosis. Even in juvenile and infantile types, the classification system is not of much value because their entire treatment modality is different. Their entire treatment concept is different. This is predominantly to give an outline for management. Initially, there was something called a Skin's classification. That was a very good classification. But however, it didn't give a clear-cut idea about the treatment modality which is required. When to, what to fuse, which vertebra to which vertebra. So 33 vertebra are there. Which one I will fuse, which one I should leave. So that was a major drawback of King's classification, though it was followed widely for about 20 to 30 years. Then LENKE came up. Dr. LENKE, at his very young age, he developed this classification, and now this is being followed widely. Type 1 is main thoracic because that is the commonest type. As I said, main right-sided thoracic curve is the common type in girls. So main thoracic, double major, triple major, thoracolumbar or lumbar, and thoracolumbar with main thoracic. I'll go one by one. So this structural criteria we have discussed whenever there is side bending COBB. See, as postgraduate, if you are able to say about side bending COBB, that is more than enough. You need not go into the kyphosis because it will be slightly more confusing. So I just ignored that portion. But when you specialize into a deformity surgeon, spine surgeon, the second point is very, very important than the first point. It becomes much more important than the first point. But let's not get into the details, and I don't want you to confuse further because I want you to take some sweet memories after this class rather than some scary moments. So coming to the curve type, again, it is purely based on the structurality of the curve. Main thoracic means only the main thoracic is structural. The rest two, proximal thoracic and lumbar curves, are non-structural. Double thoracic means, as the name denotes, proximal thoracic and main thoracic are structural. Double major means, the name denotes, main thoracic and thoracolumbar or lumbar curve. They are structural. But the thoracic will be the major one. Okay. And triple major means all three will be structural. Again, the example which I showed comes as, I'll come. Suppose the example which I showed, if the lumbar curve is not correcting, it becomes a triple major because the main thoracic is the major one. Type 5 is a single thoracolumbar or lumbar curve, which means only that curve is structural. Even though there is a thoracic curve or a proximal thoracic curve, they are all non-structural, which means their side bending COBB'S is less than 25 degrees. Type 6 is main thoracic as well as thoracolumbar curve. Both are structural. What is the difference between type 3 and type 6? Type 3 is also both main thoracic and thoracolumbar are structural curves. Type 6 also, main thoracic and lumbar curves are structural curves. But the difference comes in the which one is a major curve. As I discussed, if the main thoracic curve is more, if it is 100 degree and the lumbar curve is 50 degree, that becomes the type 3. Whereas if the lumbar curve is 50 degree and the main thoracic is 40 degree, both are structural, then the lumbar becomes the major curve. So that becomes type 6. You can ask, what is the difference? And the 10 degree, 20 degree, type of no, the entire treatment is different. The fusion levels are different. Everything is different. Okay. So that is why it has been classified like this. And this is one of the advantages of LENKE system over the King system, because King's classification, they were focused mainly on the thoracic curves. Lumbar curve and the type 1 motor thoracolumbar lumbar curve, but most of them, they were not focusing on the this thing. It was mainly focused on thoracic curve. Thoracic curve, thoracic curve apex, but lumbar curve structurality, that is why they landed up in many failures. LENKE என்ன பண்ணாருன்னா, lumbar curve னு ஒன்னு இருக்கு, நீங்க என்ன compensatory curve வந்து அவ்வளோ, how can you leave it so in a lighter way? You take them also. That is very important. அதையும் நீங்க எடுத்தாதான் ரிசல்ட்ஸ் நல்லா இருக்கும்னு they came up with this. Coming to lumbar spine modifier, அதாவது நான் சொன்ன மாதிரி thoracic curve ஒன்னு இருந்ததுன்னா, most of the times there will be a lumbar curve. Lumbar curve non-structuralா இருக்கு, ஆனால் sometimes it can be like this. A na the CSVL between the pedicles, B na the CSVL touches the apical body, and C na CSVL is completely medial. Can you see this? The example which I showed you, my case, it is a lumbar curve. It is a non-structural lumbar curve. So it becomes type 2 அதாவது double thoracic curve ரெண்டு thoracic curveம் structural criteria இருந்தது, so it becomes double thoracic curve. But lumbar curve வந்து we saw it from 50 degree it came to 5 degree, so அது non structuralனு போயிருது. ஆனாலும் அவ்வளோ பெரிய lumbar curve இருக்கு, நம்ம அதை ட்ரீட் பண்ணணுமா பண்ணக்கூடாதா, whether I have to fuse that or no, though it is a non structural curve, how can I leave that curve just like that and come out? அதுக்கு தான் இந்த lumbar spine modifier. So that case which I showed you, my case becomes lumbar modifier type C. Again, it is very, very important for treatment modality. Very, very important. Then comes sagittal profile modifier. It's very easy. Hypona less than 10 degree, normal na 10 to 40 degree, hyperna 40 degree. You may ask a question. You are talking so much about the side bending view, structurality, AP பத்தி பட்டு பேசிட்டு lateral view பத்தி காட்டவும் இல்ல பேசவும் இல்ல அப்படின்னா, lateral view is again important to maintain global sagittal balance, but its importance comes when you are treating the patient, not in classification systems, not for exam purposes, but as a surgeon when you are treating, you have to view the lateral view very closely, because எந்த ராட ஃபர்ஸ்ட் போடணும், எந்த ராட ரொட்டேட் பண்ணணும் எல்லாமே depends on your sagittal profile. Suppose hypokyphosis இருந்ததுன்னா there is a technique, you should put this rod first and rotate this rod first அப்படின்னு இருக்கு. hyperkyphosis இருந்ததுன்னா இந்த சைடு உள்ள ராட தான் ஃபர்ஸ்ட் போடணும், இப்படி தான் ரொட்டேட் பண்ணணும், இப்படி தான் கம்ப்ரஸ் பண்ணணும். that is for intraoperative management. So you can by heart this, but for exam purposes it is not required. So this is a treatment outline which was made by me, referring after reading few books and articles to make it very simple for postgraduates. Adolescent idiopathic scoliosis. Adolescent idiopathic scoliosis, first is skeletally mature or immature and பார்க்கணும். So if it is skeletally immature, patient skeletally immature but curve less than 20 degree அப்படின்னா, just observe. Do x-rays every 6 months or 1 year. எதுவும் பண்ண வேண்டாம். 20 to 40 degrees na orthotic treatment, give brace, Milwaukee brace, Boston brace. But I have been in a place where I did my fellowship there. My boss used to go to Bhubaneswar, Dr. Shankaracharya. There is a nation's biggest orthotic center, and they used to do a phenomenally excellent braces for scoliosis with proper 3-point pressure. Whereas the braces which are available here are not sufficient, it will not be effective to treat scoliosis. Suppose if you are using orthotics and brace as a treatment, then it has to be worn at least for 23 to 24 hours per day. So that is mandatory. And next, if the curve is greater than 40 degrees, then surgical treatment is the option for skeletally mature patients. Why, you may ask, why have you divided this into skeletally immature and skeletally mature? Because the surgical treatment is totally different in a skeletally immature patient, and it is totally different in a skeletally mature patient. Suppose if the patient is skeletally mature by menarche attained, RISSER'S grade la nalla irukku, grade 5 irukku, triradiate cartilage எல்லாம் closed, everything is okay. Now less than 20 degree, don't do anything. Follow up kuda varavanda. You can just tell them you are completely skeletally mature, you need not come for follow up, you can just go. That's what literature says. 20 to 40 degrees, they are in the gray zone. You can just ask them, observe every once in 2 years or 3 years, you can just do some x-ray. After that, the rate of progression is hardly 0.5 to 1 degree. Again, you see the heading, adolescent idiopathic scoliosis. I'm stressing this point. It is not for congenital scoliosis. I'm telling you, okay? So 20 to 40 degrees, you can observe. Greater than 40 degrees, surgical treatment is the choice. Don't ever wait. There is no point in waiting. The patient will decompensate further, it will worsen, and you will land up in doing a very, very difficult surgery at a later date. So last 2 slides about fusion levels. This is romba konja hi-fi. Usually they will not ask you in exam, but as an orthopedic surgeon, or gross idea irukonu avladhaan. So if you guys are interested, you can just go through this article. It is a fantastic article, just 7 or 8 pages, which has given in a very clear way about choosing fusion levels. எந்தெந்த லெவல்ல ஃபியூஸ் பண்ணணும், மேல எங்க ஸ்க்ரூ போடணும், கீழே எது வரைக்கும் போடணும் அப்படின்றத கிளியரா கொடுத்திருப்பாங்க. That it's this topic, choosing fusion levels in adolescent idiopathic scoliosis itself, is a 1 to 2 hours topic to be discussed. I'm not getting into the details. And again, just a mention about the PUMC classification. I heard from my PGs that it is being mentioned in the latest textbook of Campbell and other books. PUMC means Peking University Medical Classification, Medical College Classification by the Beijing Medical University. It has taken the pitfalls of LENKEs. LENKEs la konja pitfalls. For example, neenga நம்ம கன்ஃபியூஸ் ஆவறதே தான். எப்படி 25 டிகிரி ஸ்ட்ரக்சராலிட்டிக்கு வச்சாங்க. ஒரு பேஷண்ட் இப்படி குனியுவான், ஒரு பேஷண்ட் நல்லா டில்ட் பண்ணுவான், ஒரு பேஷண்ட் டில்ட்டே பண்ண மாட்டான். ஸோ இட் இஸ் வெரி வேரியபிள். ஸோ அந்த பிட்ஃபால்ஸை என்கவுண்டர் பண்றதுக்கு வந்தது தான் பியூஎம்சி. லெங்கீஸ் கிளாசிஃபிகேஷன்ல இருக்க மாதிரி இந்த மாடிஃபயர் அந்த மாடிஃபயர் இந்த அப்படிலாம் எதுவுமே கிடையாது. லெங்கீஸ் கிளாசிஃபிகேஷன்ல if you take the curve types and if you take the proportions of the modifiers, it will come to totally about 42 subtypes. Whereas PEMC classification motta subtype 15 da, and the entire treatment is based on that. And this latest initially PEMC classification came in around 2003. They modified their own classification now by adding 2 subtypes. This was published in 2019. So again, if someone is very much interested, you can just go through this classification. Otherwise, for exam purposes, it is not at all needed. Idella konja completion sake kaga I am just going through. The general principle, major curve and structural minor curves should be fused. Underline that word, structural minor curves. You can ask, sir, suppose lumbar curve structural illa, it's a non-structural minor curve. Shall I leave it? Yes, you can leave it. You can do selective thoracic fusion. Non-structural minor curves can be allowed. As I said, the compensatory curve, it is just compensating for the curve above, and it is still moldable. That is why it is non-structural. It goes less than 25 degrees. So if you correct the curve alone, and if you leave the non-structural curves, time poga poga, it will compensate. This is general principle. Okay. But there are many ifs and buts. And when you are doing any scoliosis, these are the points which should be done. Adequate lateral release is the key. When I went to US for deformity training, the one thing which the surgeon used to say for each and every case and for each and every level, he used to say this word: adequate lateral release is the key. Adequate lateral release is the key. So that is number one. Maximum screws should be put at the concave apex, but it is very, very difficult to put at the concave apex. It is better to put on the convexity. I mean, it is easy to put on the convexity, but as much as possible, you should put at the concave apex. Adhukku enna pannumna, pre-op you should go and sit in the PACS room, and you have to see the CT scans. You should see the thickness and orientation of the pedicles. I usually do not use C-arm regularly for scoliosis. I usually read the pre-op CT scans and I just go with the 3-dimensional orientation. I mark the CT scans and I take a note in a paper and I stick it in the OT room. Because C-arm la vandu problem enna, you have to orient, you have to tilt the C-arm so much, you may not be able to get a very good view. But initially, definitely yes, you will be using some 30 shots or 40 shots for one level. That is okay. Multi-level facetectomy, it is otherwise called as Ponti's osteotomy. Ella level of faceting you have to knock off. It is mandatory. If you have to do a curve correction, you have to do this. And most of the times concave rod first to put a try pannum, because it is better. The amount of correction which you will achieve is better with the concave rod first. Again, it is difficult to put a concave rod first, but with training and with techniques, you can do that. As I said, rod translation. Rod inga porom curve இப்படி இருக்கு. So you have to curve அப்படியே translate பண்ணி ராடுக்கு கொண்டு வரணும். So that is very important. Cantilever bending. So you bend the rod as எப்படி வேணுமோ bend பண்ணிட்டு அப்புறம் you bring that rod to the screws. That is called as cantilever bending. That will again correct the curve. Rod rotation. Rod போட்டாச்சு. Now you use the rod and rotate the spine. And final thing is direct vertebral rotation. This is the latest technology which is available in most of the imported instrument and even Indian instrument system, where you use the screws. The pedicle screw is a 360-degree screw. That is the anterior column where you can purchase. So if you screw porter, you can use that screw and you can derotate the vertebra. As I said, it is a rotational deformity. So and the rotation correct panna, deformity automatically correct down. So basically what you are doing is this. You can see this picture. In the bucket handle side la irukradha nera thirupuradhu, adhaadu you are making the thorax, the scoliosis In the thoracic region, you are making it as a thoracic kyphosis, and the scoliosis அப்படியே திருப்பி thoracic kyphosis வைக்கிறீங்க. That is the principle of rod rotation maneuvers. So you rotating the rod, sagittal profile க்கு தகுந்த மாதிரி rod rotate பண்ணி screw போட்டுட்டு அது அப்படியே derotate பண்ணும். So I would like to end this topic by the same case example which we discussed. So this is what it is. So this is what I did. I put the screws at all levels, and the number of screws, it depends. மேலையும் கீழையும் கன்ஸ்ட்ரக்ட் ஸ்ட்ராங்கா இருக்கணும். 2 above 2 below கம்பல்சரி. அதுக்கப்புறம் நடுவில் எவ்வளவு ஸ்க்ரூ போட முடியுதோ போடலாம். ஸ்டாகர் பண்ணலாம். The literature says that you need not put screws at every level. Okay, and then I have done multi-level. I'm not able to use the pointer, but I have done multi-level Ponti's osteotomy. You can see at the top levels la pathina gap theriyum naduvula. And this is after putting adequate bone grafts, and this is after rod derotation, cantilever bending, everything. This is the post-operative view of the same patient. She's a 13-year-old girl with adolescent idiopathic scoliosis. There was no anomalies in the MRI, and the CT scan was without any vertebral anomalies. So again, can you see the vertebral nalla 54 la pakkawa you can correct it. Whereas the proximal thoracic, most of the times it will be rigid. Okay, but what you have to see is shoulder balance, clavicular line, and the T1 is very, very important. T1 vertebra should be horizontal. Tilt irukko koodadu. Tilt irundana patient decompensate aruvaanga. T1 should be horizontal. Similarly, the lower end vertebra, general principle ave, the lower end vertebra should be neutral, should be center, and should be horizontal. That is, ரெண்டு படிக்கலும் ஒரே மாதிரி தெரியணும். It should be in the CSVL as much as possible. It should be horizontal. Tilt ஆயிருக்க கூடாது. Tilt ஆயிருந்ததுன்னா கீழே ஒன்று இருக்க விட்டா தான் அது tilt ஆகணும். That is again getting into the in depth. So this is the gross. So you have to remember these three words: horizontal, stable, and neutral vertebra. அதுதான் invertebraவா இருக்கணும். Then it becomes easier. So this is the preoperative clinical picture. You can see right-sided curve, whereas left shoulder is at a higher level. See, it is a decompensated curve. See how much the spine is going away from the gluteal cleft. That is the gluteal cleft which I have marked. It is completely deviated to one side. And this is the post-operative image where you can see the curve is completely coming towards the center, and the patient is able to stand straight. So this is how we have to plan. So again, I thank Professor Tirunarayanan sir for giving me this opportunity to interact with you all and to share some knowledge which I know in scoliosis with you all. And now we'll start the discussion part and we'll start the clarifications. Hello. Sir. Yes, sir.
Sudhir, thank you very much, ma. Fantastic.
Yes, no problem.
I think there are a lot of I think I think we have to see this presentation. Yes, I know it's getting recorded.
Yes, sir.
So I think I request the PGs to go through the presentation again. It is not very easy. I understand you made it easy, but it is still not very easy. So the PGs have to go and see each vertebra, apical vertebra, stable vertebra, end vertebra, everything. I think they have to go and see. I think then only it will be easier for them. Anyway, I think we'll fantastic topic, very difficult one. A short time, I know it's very difficult. I think this is if we read this much, it is enough. And my only request is, I know you gave 2 articles. You gave reference of 2 articles.
Yes, sir.
The link of the full article. It's very difficult for the PGs to sometime to go and search for the article.
No, I have the articles here, sir. I'll send it.
I'll just put it in the group.
Sure.
So that it will be easier for them to refer.
Sure,
if you tell them to go and refer, it will not happen.
Sure, sir.
If you give them the article, then it will be easy for them to go and read. So we'll leave it open, and Ram Prasad, any PGs, and even Arun, you can go ahead and ask Sudhir whatever the questions you want.
Arun, how are you? Hi, Arun.
Arun இருக்காருன்னு தெரியல.
Arun இல்லையா? சரி.
Arun இருக்காருன்னு தெரியல. இருந்தாரு
நடுநடுல வந்தாரு. Anyway, Sudhir, it was excellent. அதாவது no words to comment regarding the excellence. See, so much pain you have taken to slides. Each slide is perfect in its own way, actually. So self-explanatory. So before you start explaining, when we see the slide itself, we are able to understand. Like that, you have prepared the slide and you have focused on important things which as a beginner PGs have to know.
Yes, sir. Thank you, sir.
At one point, you said that in India, first time this scoliosis detection program is being launched.
Yes,
this
sir.
year or when was it launched in India?
Sir, it was launched last year. They have identified zonal members. So over zone ko and spine surgeons they have allotted. Like for example, in Chennai, Dr. Appaji and myself have been allotted as the zonal members for scoliosis screening program, and we are targeting 10,000 students in each zone. Like Chennai 10,000, Pune, Mumbai, Delhi, and Andamari. So National Scoliosis Registry we are planning to form, sir.
Where will you look for the children? In all the private schools or government
Illa
schools?
sir, try pandrukkom sir. Some schools getting consent is very difficult. Konja high-fi schools la. I have done in few corporation schools and I have done in few schools near Coimbatore. அது பண்ணிட்டு இருக்க ஆரம்பிக்கும் போது we started last September. அது ஆரம்பிச்சு 3 ஸ்கூல் முடிக்கிறதுக்குள்ள இந்த கோவிட் வந்துருச்சு. So we are not able to proceed further. And we are trying to get into rope into other schools also, sir. Government school, corporation school, any school.
Okay, what is the role of this RBVP program? This Rashtriya Bala Vikas program is launched by the central government.
Okay,
and
sir.
It is intensely, religiously followed by school health doctors also.
Okay,
so
sir.
All the school health doctors belonging to the government setup, they
Yes.
they have their own mobile units and they go to each school and they look for other things apart from the scoliosis also.
Oh,
So
okay.
I feel these doctors, if they are trained up adequately,
Okay,
they can
sir.
also do the same job. At
Yeah,
least
definitely.
preliminary workup they can do, and then they can refer to you for expert workup.
Sure, sir.
So
definitely.
This
that
thing
can
is
be done.
happening actually already. RBVP, Rashtriya Bala Vikas program, I think.
Oh, okay, sir.
Yeah. This
Okay,
is
sir.
happening already in Tamil Nadu.
Oh, okay,
And,
sir.
In all medical colleges, in all joint directorates, this program is religiously followed actually.
Okay, sir. Okay,
So I
sir.
think you can coordinate with the joint director of each district. Joint
Oh,
director will be
okay,
there
sir.
from DMSI
Sure, sir.
for each district. You can coordinate with them
Okay.
and you can gain more access into these, at least the government schools.
Okay, sir. Sure.
Yeah, that was
Sure.
one thing. And then regarding this Adams test, there's always a confusion. Most of the people are thinking that Adams test per se is to identify whether the curve is structural or functional. But
Yes, sir.
Going through the books, I found that by doing the Adams test, there is forward bending.
Yes,
You
sir.
just identify that there is a rib hump or not.
Rib hump. That's all.
Yeah.
In
So what
yes,
is the
sir.
purpose of Adams test? I mean, in exam, what is the purpose? If you asked, you are going to find out the rib hump or
Actually, yes, sir. Actually speaking, it is for rib hump, but rib hump irukkrade, it means there is a curve. Indirectly, it means there is a curve and it is a structural curve. Because structural ana mattum dhaan thoracic cage tilt avum. Adanala dhaan for at a beginner level, we say that Adams forward bending test is positive. It's a rigid structural curve, which means the thoracic cage has undergone deformation. So basically, Adams forward bending test is to know the rib hump, and then you do a scoliometer measurement. But for PG wise, they can say that it means that the curve is a structural rigid curve, sir. Based
maybe
on
the inference of the Adams test is structural or but sometimes the other thing is suppose the patient is there, the rib hump is not that much prominent, and in that situation we used to say when there is a structural curve in one patient and functional curve in another patient, we ask the patient to bend forward, the curve disappears, then we call it as
structural curve.
And when the curve disappears, it is called functional. So this should not be equated with Adams test, I think.
Yeah, exactly. That should not be equated. And second thing,
slowly the words have started mincing.
Yeah, yes, sir.
And the sentence has inference has totally changed. And nowadays, thinking that bending forwards, the scoliosis disappears, it is functional. And bending forwards, the scoliosis doesn't disappear, it is structural. This is the reason why we are doing Adams test.
Yeah, because it indirectly means that 100% there is a curve. Adams forward bend test with rib hump thoracic deformation, it means there is a curve. So that is why the people started telling that do Adams forward bend test. If you see something, it is a structural curve because thoracic cage undergone deformation. So indirect meaning. So though it is not directly
indirect meaning, but directly what we have to say is Adams test means the rib hump. That's all.
Yeah.
Indirectly, we can make the inference that rib hump is there. It is structural.
Yes, sir.
Okay. That is one message for PGs. Just through your with your concurrence, I wanted to
emphasize
that one.
Sure,
and third thing,
yes,
you have shown a very massive curve which you have corrected and achieved a very nice reduction also.
Yes, sir.
All the thoracic and upper thoracic and lower lumbar, everything has corrected very well.
Yes, sir.
But what will happen to the, as if PG should not think that this is a bony surgery and bony correction alone, what will happen to the spinal cord, the nerve roots, which are all from the childhood, it is contracted and small, length is small, the nerve roots may get stretched, the dura may get stretched. A lot of things are there inside the column, vertebral column.
Yes, sir.
So what will happen to that?
Yes, sir. Now, nowadays it has become mandatory that you use neuromonitoring for scoliosis and kyphosis correction. Medico-legally also, we cannot save ourselves if the patient goes on for some deficit. So definitely, as you said, it is absolutely correct, sir. The amount of correction depends solely on how much the spinal cord will allow you to do. Some curves like this, they will allow you to correct this much, which is more than 70%. Whereas some curves, even when you cross 60%, the patient may develop some dropping signals in neuromonitor. In those cases, you should stop. Never ever attempt to correct more. The only thing which you can do in those in those curves is maintain the coronal balance, shoulder level and coronal balance. Curve 60 degree, 70 degree irundhalum, it is okay, but maintain the balance. Pelvis, shoulder, and straight balance, that has to be maintained in those type of curves. If you are not able to correct because the signal dropped, as you said, the spinal cord will undergo stretch, the spinal cord may undergo some arterial changes. So neuromonitoring is mandatory without any doubt. It is mandatory. In the wake up test, adala, yes, okay, but adala exam purpose da, sir. But now without neuromonitoring, we are not supposed to touch deformities. Medico-legally, we lose the case. And second thing, there are many things, hypothermia, anesthetic agents like inhalational anesthetic agents, all those things should be discussed with the neurophysiologist and the anesthetist before starting the procedure. It is very, very important.
What is the age of this patient which we have operated?
13 years old girl, sir. 13 years old girl.
I see. 1-3.
1-3, sir. 1-3.
So, do you think that younger the individual, better the elasticity of the cord structures and duramen structures? And
definitely, sir.
Or,
definitely, sir. Definitely, we can. The younger the age, the curve. I mean, the better the correction. Because this patient, if you see at 20 years, that is after 7 years, lumbar curve structural correct then it becomes very, very difficult. So earlier we see, we have to intervene at the earliest possible. Even if we see the patient at 6-7 years, for example, if it is a juvenile scoliosis, which is 50 degree, we should not say that wait till skeletal maturity. We have to go ahead with other procedures like growth rod technique, magnetic rod technique, and other procedures are there. But earlier the better. Scoliosis, earlier the better, sir.
Moreover, according to the algorithm which you have yourself designed, which you showed in the slide, one slide.
Yes, sir.
Up to 40 degrees, you mean to say that we can correct with particularly immature, skeletally immature individuals, we can correct with prosthetics, or that children also we can go for surgery if patient.
No, sir. Less than 40 degrees. If you are able to use a proper orthotic, we can use, sir. Abdilana, uttu observe panna mattum podum, sir. 40, if it is going beyond 40 degrees only, we have to correct it. Till that, use a good orthotic. It's not actually speaking, orthosis proper orthosis which will not correct, which will not give proper 3-point pressure. In that case, we can just observe. If it crosses 40 degrees, we can go ahead. Otherwise, we can just leave. And it's
or is there any criteria to say, for example, there is a rapid progression of scoliosis. It's not exceeding 40 degree, but you have seen it as a 10 degree. And after a period of 6 months to 1 year, it has become 20 degree, and another 6 months it becomes 30 degree. So there is a rapid progression. Then the same 40 degree should be applied, or
Yes, sir. Even if there is rapid progression, suppose 10-degree curve, after 6 months, it is 1 year, it is becoming 20 degrees. We can wait. Only we can wait up till 40 degrees. 40 degree ki mela pogumbodhu dhaan we have to intervene, because we can give some adequate amount of time for the rib cage and everything to develop and mature. We have to postpone the surgery, but 40 degree ki mela poidna piravu there is no point in postponing. So adanala dhaan till 8 years fusion should never be thought of for scoliosis. Fuse பண்றத பத்தி யோசிக்கவே கூடாது till 8 to 10 years, because the alveolar maturity will take place till 8 years of age. Never ever think about fusing the spine till 10 years. I personally will not fuse the spine even if it is 12 years. So 10 years, 12 years varaikkum use the growth modulation techniques, use the growing rod technique, Sheila technique, and the nariya techniques other than use pannu. Never ever think of putting pedicle screws and fusing the spine. We should not do that.
So we can operate, but
yes.
fusion should not
other
be
techniques done. Fusion should not be done, sir. Definitely no.
And what is the role of surgery in cosmetic problems? Patient is having cosmetic problems.
Yes, sir. See, the most important, the only complaint with which the patient will come to you in most of the cases is cosmesis.
Cosmetic, yes.
So my professor used to say always, scoliosis is a cosmetic surgery. So anga vandi heroic mechanisms ellaam vida balance dhaan mukkiyam. You have to look at the balance. Curve, X-ray curve irukkalam, but the balance, again, UK where I was trained, there was a surgeon named Gravett. He will not concentrate on bringing to 0 degree or 10 degree. His only aim will be to balance. T1 straight irukano, end vertebra straight irukano, it will be in the stable zone, shoulder balance. That's all. Even if the curve is 50-60 degree, he will stop and he'll come out. He'll say the patient has come for cosmesis. So post-operative aggressive panni tilt maaridichna, again it's a big problem. And I personally, for example, this patient, I use a curvy linear incision over the curve, and after you do a good amount of correction, the curve will be, the incision will become straight. I had that picture, I didn't put here. But if you use a straight incision after curve correction, that will look very ugly. Some patients will be very unsatisfactory with that, and I normally use subcuticular stitches, no staples, because it's at the end of the day, it is a cosmetic procedure. Konja plastic surgeon and the marla vandu we have to think about it. It is very important, sir.
Sudhir.
Sir, yes, sir.
Yeah, there are a couple of questions. Dr. Fakhruddin and Dr. Prabhakar also want to.
Yes, sir. Yes, sir.
Fakhruddin,
hello, Dr. Fakhruddin, orthopedic surgeon.
Yes, sir. Yes, sir. Yes, yes, சொல்லுங்க சார்.
இப்போ உங்களுடைய பிக்சர்ல more than 100 degrees thoracic curve கரெக்ட் பண்ணிருக்கீங்க. only posterior கரெக்ட் பண்ண முடியுதா?
Only posterior. இல்ல சார், only posterior.
The more than 90 degree curve, structural curve is very difficult to correct in posterior approach அப்படிங்கிற மாதிரி.
Correct. Usually rigid curves, we can go ahead with anterior release followed by posterior correction. But in the curve la vandu I was aiming, since the lumbar curve corrected significantly, I was aiming good amount of correction. நான் aim பண்ணிட்டு போனது ஒரு 50-60 degree and balance க்கு தான் போனேன். I didn't expect this much, but what I did was I followed Dr. Munish Gupta. He is in US. He is one of the topmost surgeons who is with LENKE in the world. So he is the one who is writing the classifications, everything. He used to do segmental osteotomies and over vertebra move panni katvar. After doing proper Ponti's osteotomy, he used to use a towel clip and he used to use to move like this. He'll say your release is complete only with this. So I followed that technique, proper release complete up on it. Then I followed the concave rod first and translated. And it came relatively well. But I didn't think about anterior procedure for this patient, because I thought since the lumbar curve is correcting significantly and the proximal thoracic curve was correlating with the shoulder imbalance, I thought by going to D2 and with stopping at L3 or L4, I thought I'll be able to achieve the balance.
Okay.
Prabha wanted to ask some questions, sir. Prabha?
Hello. Sir, I'm Prabhakar, sir, from Rayapata Hospital, sir.
Yes, sir.
Sir, just for teaching PG, how to clinically measure the COBB'S angle using scoliometer. Most of the time, PG is asked to do that using scoliometer. Do you have any pictures, sir?
Scoliometer picture, net la ulladha sir irukku, but ennoda scoliometer I have it in my hospital clinic la. So adu eppadi irukuna, just நம்ம இந்த இது மாதிரி இருக்கும் சார், நம்ம இந்த கார்பெண்டர்ஸ் யூஸ் பண்ணுவாங்கல சார், what do you call that? ஒரு இது மாதிரி லெவல் பாக்குறதுக்கு யூஸ் பண்ணுவாங்கல்ல சார் அந்த
Ah,
மாதிரி
yes, sir, yes.
அதே மாதிரி
Yes,
ஒரு
sir.
ஸ்கேல்
bubble
அந்த மாதிரி similar to that, but அதே மாதிரி ஸ்கேல் மாதிரி இருக்கும் with the curve in that. So நீங்க அந்த ரிப் பேஷண்ட் ஃபார்வர்ட் பெண்ட் டெஸ்ட் பண்ண சொல்லிட்டு நீங்க அந்த ஸ்கோலியோமீட்டர் மேல வெச்ச உடனே உங்களுக்கு அந்த டிகிரி தெரிஞ்சிடும் சார். தட் ஆக்சுவலி மீன்ஸ் தி அமௌண்ட் ஆஃப் அபிக்கல் வெர்டபிரல் ரொட்டேஷன் சொல்லுவாங்க, எந்த அளவுக்கு அது ரொட்டேட் ஆயிருக்கு கிளினிக்கலா காப்ஸ் ஆங்கிள் மெஷர் பண்ண முடியாது சார். ஸ்கோலியோமீட்டரோட அந்த அபிக்கல் வெர்டபிரல் ரொட்டேஷனை மட்டும் தான் நம்மளால மெஷர் பண்ண முடியும். யூசுவலி தே சே about 5 to 7 degrees ஸ்கோலியோமீட்டர் வந்து corresponds to about 15 to 20 degree of Cobb's angle. Rough, but it is not this thing. Cobb's angle can be measured only in X-ray.
Sir, sorry, edukku sir for measuring apical vertebra sir?
Illa the truncal rotation. Basically, it is used to measure the truncal rotation. எந்த அளவுக்கு trunk rotate ஆயிருக்கு அந்த forward complete அப்படின்றத பார்க்கிறதுக்கு தான் சார். That signifies the severity of the curve.
Okay, or rough guide avladhaan sir.
rough guide, but in depth details kulla நம்ம போயும்போது clinical, I mean whether to fuse selective thoracic fusion or lumbar fusion அப்படினா யோசிக்கும்போது இந்த criteria எல்லாம் வரும் சார். apical vertebral translation, apical vertebral rotation, அதோட ratios அதெல்லாம் எடுத்து தான் selective thoracic fusion or lumbar modifier A B C அது வந்து எல்லா parametersயும் எடுப்போம். So அப்போ அது important.
Oh. Sir, one more question, sir. Meta angle,
yes. Sir, meta angle is predominantly for infantile and juvenile scoliosis. It is not for adolescent scoliosis. Infantile and juvenile scoliosis la mattum da meta angle significant. It means the rib, for example, if it is less than 20 degree, the angle இப்படி தான் இருக்கு. நம்ம இந்த vertebra, this is the vertebra. The angle, the rib is like so less than 20 degree na இப்படி தான் இருக்கும். So in the angle அதிகமாயிட்டு போக போக it means the curve is progressing, it is rotating and it is tilting.
Okay.
So on the three-dimensional picture she is taking it into account because rib it's a one which is growing along with the spine, so it is basically the relationship of the rib with the spine. So அதே மாதிரி இப்படி இருக்குனா பிரச்சனை இல்ல, ரிப்பும் வெர்டிப்ராவும் இப்படி இருக்குனா the progression will be less, whereas rotate ஆக போயிட்டே இருக்கு அப்படினா as I said the rotation, the progression of the curve is so the rotation is so significant, the rotation is so fast that spine is progressing, the deformity is progressing so fast that the rib is going along with the spine, adunala keela vara mudla, so it is just rotating along with the spine. And that is called as face to rib. So whenever there is overlap of the convex rib over the convex vertebra, it means the curves will progress faster and they have a worse prognosis. So avangala immediate நம்ம வெச்சிட்டே இருக்கணும், 6 months once observe பண்ணனும், immediate வேற ஏதாவது procedure we have to undertake rather than waiting. We have to explain the guarded prognosis. அதுக்கு தான் sir vertebral angle. It is mainly to know the progression of which curves will progress fast, which curves will progress slow.
And Sudhir, in your presentation,
sir,
Sudhir, in your presentation you said Cobb's angle more than 25 degrees structural.
Yes sir, side bending.
So in that case, pardon?
Yes sir, side bending view, side bending.
Side bending la what do you mean side bending?
If the Cobb's angle in side bending view is more than 25 degree, it is a structural curve.
Okay, so in that case you know that there is a structural curve.
Yes,
and do you want the curve to become 40 degree to operate or
no sir? இன்னொரு curve இருக்கும் இல்லையா சார், இன்னொரு curve பெரிய curve இருந்துச்சுன்னா அது if it is more than 40 degree we have to operate sir. Suppose ஒரே ஒரு curve தான் இருக்கு, அது as you say normal Cobb's is 50 degree, but structurality படி side bending la it is coming to 20 degree na we can wait.
Wait, now what will you do in the interim period? You will give some prosthetics or you will just observe?
For young children we'll give prosthetics. We'll ask them to wear 23 hours per day except while going to bathrooms, whereas in adults we'll say eventually the patient will require surgery, the patient it will progress அப்படினு சொல்லிட்டு temporary or brace கொடுக்கலாம் சார். But skeletally mature la evidence is very clear that brace will not work for adolescent and other things. And congenital scoliosis, the role of brace is very minimal. Only in idiopathic scoliosis with skeletally immature patient la dhaan brace ஓரளவுக்கு வேலை செய்யும், provided 23 hours போட்டுருக்கணும். 8 hours 14 hours la it won't work. Constant 3-point pressure has to be applied over the spine.
Sudhir, just one more thing.
Yes, sir.
Just what are the references that the PGs have to go and know to? One of the articles, and of course, which books, any books and reference.
Campbell.
So, இது படிச்சா போதும். இது படிச்சா போதும் அப்படின்னா, I think they can restrict themselves to that. Okay.
Campbell, sir. Campbell operative technique தொடவே வேண்டாம் sir. Let them not get into the operative technique at all. மூடி வச்சிட்டு போயிடுவாங்க. Only அந்த white portionல இருக்கிறத மட்டும் படிக்கலாம். அந்த cream color portionல கொடுத்திருக்கிறது படிக்கவே வேண்டாம். Basic principle மட்டும் தெரிஞ்சுக்கிட்டாலும் போதும். But Campbell is far more than sufficient, sir. ரொம்ப interested candidates யாராவது இருக்காங்க ஸ்கோலியோசிஸ்ல ரொம்ப interested இருக்குன்னா the articles which I will send it to you, these 2 articles. அத படிச்சா that is more than enough.
That is enough. I just wanted to tell them so what they can go and refer. So the next couple of days or 3 days, we'll give them before we go to the next topic. We'll give them time for them to go through the topics. And I think there are a couple of questions in the in the chat box.
Yes, sir.
Shall I just ask you? What are the measurements to be taken in scoliosis case in exam?
In exam, okay. Measurements wise. நம்ம சொன்ன மாதிரி you see all the inspectory findings, palpatory findings. You measure the arm chest distance, okay? And you look for the chest expansion. That is very important for scoliosis. There should be adequate chest expansion because any patient you are planning for surgery, you have to know the single breath count, pulmonary function test எல்லாமே பண்ணிட்டு தான் எடுப்போம். Chest cavity is very important. Then there is something called as costocrestal distance, but some examiners are not very much concerned about it. அதாவது iliac crestல இருந்து last reported distance. Suppose if the patient is tilted like this, on the convexity it will be more, just with common sense, and on the concavity it will be less. It shows the severity of the curve. Suppose in case of congenital scoliosis or neuromuscular scoliosis, neurofibromatosis லாம் பாத்தீங்கன்னா patient இப்படியே தான் வருவாங்க. The patient ஓட ஒரே கம்ப்ளைண்ட் வந்து costocrestal impingement தான் இருக்கும். So அங்க aim of surgery வந்து அந்த ஸ்பேஸ் இன்க்ரீஸ் பண்ணி விடுறதா. So costocrestal measurement can be taken. These 3 measurements is special for scoliosis. It is okay. Apart from you are doing the Schober's test, அதெல்லாம் regular for any spine examination. But scoliosis per se, these 3 is more than enough.
Fine. And what is the software that you use? There's one more question in the chat box. What is the software that you use to measure the COBB'S angle? Because you were mentioning about some software.
Ama sir, there is a software called a SRMC. You can download it in the Android app. So அது இருக்கு, SRMC னு ஒன்னு இருக்கு. So அது யூஸ் பண்ணிக்கலாம். அதுல எல்லா ஆங்கிள்ஸுமே வந்துரும். Even your pelvic incidence, all those sacropelvic parameters கூட you can measure. No issues.
Because now people are more concerned with digital things.
But
so I think they learn that also.
Yes, sir. But as a postgraduate, it is better. What you can do is take a normal X-ray, put it in the lobby, use a tracing paper. இது நிறைய பேர் think பண்ணலாம், this is all, but I mean I used to do it even now, even after measuring all these angles, because that gives very vital information. Sometimes நம்மளோட இந்த டிஜிட்டல் இதுல வந்து சரியா தெரியாது, பட் நார்மல் எக்ஸ்ரே எடுத்து ட்ரேசிங் பேப்பர்ல போட்டு ஃபுல்லா ட்ரேஸ் டவுன் பண்ணி மார்க் பண்றது very important. And even today I practice that for marking the angles intraoperative planning. I don't rely on
only if you practice it in your post graduation, you will practice it in your when you practice.
Yes sir,
don't do it in your post graduation. You never do that when you go outside and practice.
Definitely sir.
These are the basic things that post graduates have to learn, go and do X-ray tracing and everything that they have to do, and they have a lot of time also. Given it is not too tight and all, I think they have a lot of time. I think we've taken a lot of time of yours.
Yeah, no problem, sir. I'm happy to share this.
Sudhir, where did you do your FNB?
Gangaram Hospital, New Delhi, sir.
Oh, Gangaram.
2 years
and
I was
there. What were you doing in Ganga?
DNB Ortho from Ganga. Worked there in Ganga. Then I was in SMF. Then FNB from Gangaram. Then I was in Nottingham.
அங்க கூட ஒரு கங்கா ஜி இதோ வருது.
Nottingham, Nottingham, UK. Anga konja
your relationship with Ganga has elevated your academic learning.
Yes.